Down to 23 now.
So good morning and welcome. I love when you start with a very quiet room and you say people connect, and they really do. No, we can't shut you up. So this is wonderful. So my name is Roger Mark D'Souza, and I direct our maternal health initiative here at the Wilson Center. And most recently, we had a discussion here at the Wilson Center looking at midwifery, where we highlighted the recent report, Midwives' Voices, Midwives' Realities. And our colleague from WHO said, every brilliant idea starts with a conversation. And this is so true. So this is what we're here about today, to have a conversation. And I think we at the Wilson Center, and many of you know us very well, we serve as a living memorial to President Wilson, most recently recognized as the #1 think tank globally for transdisciplinary research by the University of Pennsylvania. And the work that we do on maternal health for us really crosses so many disciplines. We're looking to strategically position and engage multiple audiences to understand and appreciate maternal health priorities. We believe that there are certain moments in time where we are called upon to engage, to examine, to critically analyze, and to determine how to move forward on key development priorities. For us, the issue that we're here to discuss today, too much too soon, addressing over-intervention in maternity care, is one of these issues, and this is an important strategic moment for us to engage on this topic. So for us at the Wilson Center, through our maternal health initiative, we are able to do this through partnerships. And I want to particularly recognize my colleagues here at the Wilson Center who have been a key part of my team in helping us address these issues. Francesca Cameron, Nancy Chong, who's taking photos with us. Thank you to you both for your partnership and engagement. We're able to do this series in collaboration with two strategic partners for us. We have our colleagues from Harvard University's Maternal Health Task Force, MHTF, and our colleague Jacqueline Caglier is here. Jacqueline? So appreciation, thank you. Make sure that you connect with Jacqueline if you don't know her. And of course, our colleagues at UNFPA who have been so instrumental for us. You will hear from our colleagues from UNFPA during the panel, but I'd like to particularly recognize Geeta Lal, who's been a key partner for us. Sarah Craven, in the Washington, D.C. office. Rachel Monahan. Rachel, and our colleague who's joined us from London, Matt Johnson. Where's Matt? There you are. So make sure that you also connect with our UNFPA colleagues who have been such an integral part of this partnership and collaboration with us. And I'm just so pleased and excited to welcome Annika Kudnutson, who is new to UNFPA in New York, but joining us here to get a sense of how we do these events at the Wilson Center and to moderate today's panel. So Annika is the chief of the Sexual Reproductive Health branch at UNFPA, and prior to joining UNFPA, she was the head of the Swedish International Development Corporation Agency with Ethiopia and deputy head of the mission in Addis Ababa. I was very excited as I looked at Annika's background to also see that she's a registered midwife. Yeah, we like that. So Annika, a very warm welcome. I hand the panel over to you for your moderation, and we're very much looking forward to it. Welcome to all. Thank you.
Thank you so much, Roger Mark, for those words, and good morning to you all in the room and on the web, because I do think that here in the room are many important people that will be able to have that very important conversation, but without you on the web and without you watching this later on when it's all recorded and sent again and you can go back to look at it, it's so important that what we say here and this conversation gets legs and gets out to countries, because that's where it's happening. I'm really pleased to be representing UNFPA here today, moderating this session on over-intervention in maternity care. We will have, I hope, 2 hours of very interactive conversation, discussion, questioning, argumentation, and the lot. But before I introduce the panelists, and we have a very experienced group of 3 women here, that I will go into a little more in-depth of introduction in a little while. But I first would like to just say why UNFPA wants to partner on these conversations and why the series is so important that Roger Mark just talked about and we are part of, and with the Maternal Health Initiative as well. At the core of our goals for women and girls, and I'm not speaking just as UNFPA, I'm speaking as a member of the global community, as a woman, as a midwife, and as a mother of 3. That is, of course, that we want to really make every childbirth safe for every birthing woman. We want to make every pregnancy wanted. But we also want to empower every woman to be able to make decisions about what they want, about their health, about how they want their childbirth, how they want their pregnancy. So it's really equally about women's role in this. We have come a long way. If we look back at when the Safe Motherhood Initiative started in the 80s, we have come a long way in improving access, in understanding what saves women from dying in childbirth and from what keeps them from having long life, ill health, or disabilities. And we know now what causes these deaths and this ill health, and how it can be prevented and treated. And we know that 15% of all complications arise in labor. And we have come a long way on political will and midwifery. And just let me give you a very short example of how far we've come. I have been with UNFPA once before, and that was in 2005, when I, as one of the first midwife advisors, were sent to Bangladesh by SIDA and UNFPA in a joint program. My first day in the office, I went in and I said hello to every staff in the office. And I came to one of the more senior program officers and I introduced myself and I said, I'm a midwife. And she looked at me and she said, so you're a midwife? I thought Sweden was a developed country. So we have come a long way. We have come a long way also in increasing the institutionalized births. But we also have a lot of unfinished business. There is a lot that remains in access for women, a lot that remains to get rid of the 3 delays we know so much about really is at the core of the problems. But I also think that the indicator for poverty and for equity today is quality, the lack of quality. It comes in the form of underuse, it comes in the form of overuse. But increasingly, the lack of quality is about over-intervention, of losing sight of what is normal childbirth, of supporting that physiological process, forgetting it or not trusting it or fearing it, and we'll hear more, I'm sure, about all of these reasons. And so we forget about the normal process and we end up in a risk-based development. We as health professionals are there, and we should be there to support that normal process, to support the woman. And I won't go ahead here and say what you're all going to say, but I just want to say and reiterate that we at UNFPA also think that this is so important. Apart from almost human rights violations, I would say, it's also over-interventions are so costly for the health system and for countries that already have very scarce resources. Think about C-sections, ultrasound, a lot of antibiotics. And there I just heard last week in the spring meeting where I was attending a meeting on the Universal Health Access meeting, financing for that. where 2016, 700,000 people died from antibiotic resistance cause. And if that is calculated and looking ahead up to 2050, if it continues like this, that will be 10 million people dying. So we have to get it right. We have to get it right for health professionals, for policies, for health systems, but we have to get it right for women. This is very much about the status of women. And by that, I would like to introduce the panel. So I have, as I said, 3 very distinguished women here. And let me now, I have to look at my papers. So I get it right. We will have a session that starts with giving us the sort of oversight of too little, too late, too much, too soon. Yes, too much, too soon. That was right. Then we'll go to a country example and hear from India. And then we'll move into what it's really about, quality of care. And starting to give us the first oversight is Sue Ellen Miller, who is a professor of the Safe Motherhood Program, director of the Safe Motherhood Program, and a professor at UFCSC, practitioner midwife, practicing midwife, and has an extensive experience of low-income countries and maternal health there. She is the co-author to the series Beyond Too Little, Too Late, and Too Much, Too Soon, the Lancet Maternal Health series. And she's also currently editing, yes, the Reproductive Health Journal on respectful maternity care. The second speaker is Miriam Vukovic, and I couldn't give all of what they all have in their resumes, but you have it in front of you, so please read, because it's really fabulous. Miriam Vukovic is assistant professor at Georgetown University at the International Health Department. She has a lot of experience from the HIV/AIDS field, from the Global Fund, and from Tanzania. And she's teaching and has done also her research on maternal, neonatal, and child health. And last but not least, we have Dr. Saraswati Vedam. She's the lead of something very interesting, the lead innovator of the Birthplace Lab, and assistant professor of midwifery at University of Columbia. She's been a health professional for over 30 years, and she has helped influence national and international policy and given consultancy to a large number of countries. She's also convened a number of home birth consensus seminars. So I welcome you all by this, and I give the floor to Soela to start us off.
Do a little technical adjustment here, but good morning, everybody. And almost afternoon. Nice to see so many of you here, and wave out to the folks who are viewing and will be viewing.
Can I ask, because I forgot to say how we're going to do this. 10 to 12 minutes for the panelists to present, and then we'll have a very interactive discussion.
Okay, thank you. All right, so I was in this room maybe 5 months ago, and some of the same faces are here when we were doing the launch of the Lancet Maternal Health series. And just a quick overview, there were 6 papers, 3 commentaries, 77 authors. And what we found was data that really tell a very powerful story about the past decade since the original Maternal Health series came out, a current picture, and then forecasts of where we're going. The biggest finding that we had, if you can summarize it in just a few sentences, is diversity and divergence. So the burden of poor maternal health is diversity and the causes of maternal mortality. We do know what kills women: bleeding, hypertension, or eclampsia, preeclampsia, obstructed labor, those things. But what we're finding now is the chronic and non-communicable diseases, as well as some infectious processes like HIV, AIDS, obviously, and TB, will also be causes of maternal mortality. We're also seeing a very widening divergence in the inequity in key maternal health indicators. So while everybody is improving somewhat, most places are improving somewhat in care, we're seeing a wider divergence between the wealthy and the poor. And that really just comes down to that. There's a large divergence going on, and I'll get into some of that. So in the paper that we wrote, Beyond Too Little Too Late and Too Much Too Soon, we had a kind of boring assignment, and it was reviewing high-quality global recommendations for evidence-based care practices during ANC, IPC, and PPC. And, you know, that's something. But what we decided as we were doing it is that we wanted to really look at what hadn't been looked at before, which is middle-income countries, to see what their practices were, what data was available, first of all, that was reliable, but also to see who was still doing things that were specifically no longer recommended, which is part of over-medicalization, and those practices which, like C-section, which are life-saving but very harmful and costly if performed routinely or overused. And so our emphasis is also on quality care with respectful care. And that came out again, it's everywhere right now, and goes back to, I think, for the midwives in the room, some of the older midwives in the room, we were talking this as midwives so many years, so many decades of giving women respectful care. And the findings that we found were that evidence-based care isn't really quality care without respectful care. And we'll talk a little bit more about that. So what is quality maternal health care? It's appropriate, it's timely, it's evidence-based, and it's respectful. So the two polls that we found were too little, too late, which for those of us in global health has been the focus of a lot of our work in maternal health. A lack of any evidence-based guidelines, women delivering completely alone. But we're also finding now globally too much too soon, such as routine induced or augmented labors, and routine antibiotics that are given postpartum to women for no reason. Just two small examples. So I'm focusing somewhat on cesarean section rates because they are very good examples of too little too late and too much too soon, and often found too little too late and too much too soon within the same country. So these are country rates, and you can see that there is the blue colors are the low-income countries, and most of those are below 10% C-section rates, which may be too little too late, may not be capturing the women that need to be captured. In the middle here, mostly high-income countries with a few middle-income countries are this sort of middle-ish range that people around 15 to 19% is now sort of the parameter for anything. Any rates above those rates are probably doing more harm than good. 10%, below 10%, women who need care are not getting care. What was one of the many surprises that we found was that the middle-income countries are the ones with the highest rates. And I'm not sure if everything is very readable there, but the Dominican Republic, a country that I've worked in some time ago, has the highest rate in the world for overall rate for the country. And we need to sort of look down and see what is going on at a country level. This graph shows the percentage ratio, so between poor and wealthy women. So I don't know if this pointer is pointing or not. Okay, well, the largest percentage rate, the prevalence ratio between wealthy and poor women is in rural China, where the poor get very little care and the wealthiest women are getting more care than they need. So too little too late, and we found that too much too soon and too little too late exists side by side and in high-income countries as well. And I think the United States, with its now increasing maternal mortality and neonatal mortality rates and the lack of health access is one of the examples. The U.S. is the only high-income country with rising mortality, along with rising costs of maternity care. So women are dying despite having to spend tons of money and the system's having to pay tons of money. In 2010, African American women in Manhattan were more likely to die, 56 per 100,000, than women in North Korea or Vietnam, which at the time it was 54 per 100,000. That is a horrific statistic to see. Maternal mortality rates for African American women are 3 to 4 times that of white women and have been for decades. And this is despite, or maybe because, of African American women having higher rates of intervention than white, Hispanic, or Asian women. So this is a CDC graphic of cesarean delivery by what they call race and Hispanic origin of mother. So overall, C-sections are coming down tiny bits, but among African American women, they are well above the mean and are not changing at all, because these are very small increments of just 2 percentage points between each of the influence. And the American Indian or Alaska Native, this around 23, 24%, may represent good quality care, or it may represent too little too late. Or it may represent women who are just ignored and managed to come through it. Okay, so we're looking now at low and middle income countries, and we're looking at cesarean section by sector and wealth. So first we look at wealth and time over time. I'm going to take a little bit of time with this. So all across the 7-year intervals, which I think you can see, 92, 98, 2005, and 2013, more or less 7 years between each one. The poorest women had the fewest cesarean deliveries, while the richest women had much more. But as time has gone on, the poorest women are getting a few more cesarean deliveries. So the percentage rise is very small, whereas the richest group are really rising up to the levels that they are in the US, which is about 32%. So that's when you look at disparities by time and wealth. Looking at a huge country like India is very difficult to make assumptions about what happens on the ground. So we actually looked at private facilities versus public facilities and rich and poor differences. And you can see there are a lot of differences within each state and across the state. But again, if you talk about too much too soon, we've got rates here for the wealthy of 50 to about 81%. So what's going on in the world that this is happening? These whys are important to ask. Who's benefiting from this? Women certainly are losing, and so are populations, and so are donors who are giving money for programs and then seeing that the care that is given has been medicalized but hasn't been delivered with quality or with respect. So another thing that we looked at in this paper was, where is evidence-based care being conducted or not conducted across a number of middle-income countries? And as I said, it's something that hasn't really been looked at carefully, and that's because there's not a lot of evidence out there. We found about 81 countries that we could find one or more data points on for percent of women delivering with a birth companion, skin-to-skin contact, immediate breastfeeding, the things that we know are simple, inexpensive, and evidence-based good outcomes for mothers and babies. So the orange bars represent those countries where there's at least 20% of women are accompanied, according to the statistics. The blue lines are, those countries with fewer than 20% of women having a companion in labor and or delivery. And then some countries that we couldn't even count, they were less than 1% being reported in those countries, including the Dominican Republic, where we have such astounding cesarean section rates and a documented lack of respectful care. So too much too soon in middle-income countries. Let's look at the practices that are recommended by the high-quality guidelines that we reviewed. They may be life-saving, but they're harmful if they're done routinely or overused. So we looked at inductions in 24 countries. That's all we could get data on, the 81 that were World Bank designated as middle-income countries. They range from 2% to 71% in Iran. Augmentation, we found data only on 15 countries, 1% in China to 79% in India. And C-section, we did find rates for 81 countries, and the range was 2% in Timor-Leste to 59% in the Dominican Republic. And again, these are national rates, and we're not looking at every one of them in the same year. So sometimes we're comparing an older statistic, but we really, I mean, we were a team of 20, and we couldn't find very much data at the national level. Okay, episiotomy rate. We've got 11 countries' episiotomy rates. That's all that we got. But again, there's this wide range. In Thailand, you have 91% of Thai women get an episiotomy. Do 91% of Thai women need an episiotomy, require episiotomy? Is there any reason why this is going on, or any reason why any of these rates are going on? Devastating. With their mouth open, what? All right. Too little, too late, and too much too soon, certainly too much too soon, as we've seen, even in low-income and now in middle-income countries. So we were looking for equity in maternal care, neither extreme. And what the authors, not only of our paper, but of the whole series found, when they looked in detail at a lot of data, including the midwifery series that was published by The Lancet, is that the best outcomes with the fewest interventions and the lowest cost is midwifery-led care. And I know all the midwives in the room already know this and have known it for a long time, but it's nice to see it out there. So I'm going to end on a positive note, and that is that change is coming. There are some actions that are going on in a limited amount, mostly around C-section is what I'm going to talk about again. There are efforts to reduce the first C-section. So these are what are called low-risk women, or nulliparous term vertex singleton. So a woman who's never had a baby before, so she's never had a C-section before. She's at term, baby's head is down, and there's only one baby. And all of the major professional associations are working on this and have a variety of recommendations. ACNM, the California Maternal Quality Care Consortium, ACOG, the Society for Maternal Fetal Medicine, WHO, and many other groups, including insurers. Insurers are taking a stand, probably monetarily driven, but at least they're taking a stand. And in places we're finding they're refusing to pay for maternity care at facilities that don't have a sign of high quality, which is a low cesarean section rate. This is in California. What can I say? Okay, so a lot of things are being talked about. ACOG talks about redefining active labor starting at 6 centimeters instead of at 4 centimeters. So you don't have this waiting around and this no progress, which is the cause of a lot of the NTVS C-sections, and then repeat C-sections. So redefining labor so women are encouraged to move around, stay home until they're really in active labor is demonstrated by a 6 centimeter dilated cervix. No performing of inductions with an unripe cervix. Truly informed consent so that women's choices and voices are heard. Many women are afraid, they feel forced into it. Someone of authority comes in the room and says your baby's going to die unless we do a C-section right now. You know, how do you counter that with data when you're having contractions? Continuous support in labor and childbirth, decreasing reliance on electronic fetal monitoring, women moving, position changes, and then the midwifery care. And one more example, this is it. One more example from California, a study that was done by Rosenstein and published in the Green Journal. With midwifery care given to both private and public patients, there were improved rates in the rates of vaginal birth after cesarean. But there were also brought down the rates of the non-TVS. So this has now been documented. I don't know how the obstetricians felt when that came out, and it was completely midwives who were providing this kind of care with a laborist or hospitalist backup. And finally, what I mentioned in the beginning, the monetary penalties. So our messages are equity, access, and respectful care. And countries in the global community must take action to reach every woman, every newborn, everywhere with respectful, quality care. Thank you.
Thank you so much, Sue Ellen, for that very inspiring presentation. Can I ask Miriam now to take the stand?
Good morning, afternoon. Thank you very much for having us. This is a very exciting event. Thank you, Sue Ellen, for a wonderful introduction. And you touched upon a lot of the issues that I will elaborate a little bit on, looking at India in particular. And you saw already what Sue Ellen presented. There were many statistics from India, and when we talked beforehand about what we wanted to present today, we thought India would be a very good example because it has such disparities, so many, well, it has both, too little too late, and also a lot of too much too soon. And interestingly enough, with India, it's not only, the rich who get the too much too soon, and the poor who get the too little too late, and I'll get into that in a moment. So there are very interesting issues. So first of all, I wanted to give you a little bit of data on India, because some of you might be very familiar with it, others of you might have worked on other countries and not know so much about it. In general, some important health outcomes are improving in India. The fertility rate has gone down, as you can see. The under 5 mortality rate has gone down. Population is still growing, projected to grow. Hopefully, then it will taper off a little bit. But as you can see, a lot is happening in India. But there are still large inequalities. Child malnutrition is still very high. We haven't made that much progress in that area. Child sex ratios, as many of you might know, are still not very even, talking about gender issues and the need to really empower women in India. It's a very big issue. And then there are big inequalities, including urban-rural, and then also socioeconomic differences. And you can see here a little bit, and I'm not going to get into it, but you can look at it just by wealth index quintile, the differences between the lowest and the highest quintile, the stunting rates, the birth weight, breastfeeding, all those indicators we use to look at the health of children particularly. So there's a lot of disparity. The poor are less likely to access health care, and they spend less on health care and depend more on government services. The proportion of deliveries, I will have this slide a little bit later again because it's really interesting to look at. There are large differences in outcomes between the 29 states and 7 union territories across the country. And what you can see here, this is just looking at stunting, and there are enormous differences. If you look at Kerala and if you look at Uttar Pradesh, it's a subcontinent, obviously. India is huge, the population's 1.2 billion, and the differences are really, really stark. The same holds true for access to basic health services. And these are a little bit older, complete antenatal care, 2007 to 2008. And you can, again, see how southern India is doing much better than northern India and how big the differences are here. So turning from these overall statistics of well-being more towards maternal health, India has made progress. So the maternal mortality ratio fell a lot over the last 25 years, by 70%. But it is still high. India, the national data reports for last year 167 maternal deaths per 100,000 births. So it's still pretty high. However, there are huge differences again. What you saw before is true for the MMR as well. In Uttar Pradesh, the MMR is still almost at 300, whereas in Kerala, it's down to 61, which would be below the level that is demanded by the SDGs now. So there are, again, these north-south differences. And there's a huge difference between wealth quintiles as well, not just geographically. Still about, considering the large population, 45,000 women per year die in childbirth or related to childbirth in India. The government has taken action. There is a program, and I'm not good at pronouncing it. How do you, Janani
Suraksha.
Very good. JSY. And it's basically a program aimed at the states where the rate of delivery in facilities is the lowest, to give incentives to the women, basically monetary incentives, so they go and deliver in a health facility. It has worked. More women do go and deliver in health facilities. The issue, though, is that the public health infrastructure is really not very good, and then we get to the question of quality again. So women go and deliver more in health facilities, but they don't get high quality of care. And in some areas, it depends on where, but there's a 77% shortage of OBGYNs in community health centers in India. And there are 15 states and union territories that have more than 90% shortage of obstetricians, gynecologists. I don't have the stats here for midwives, but I'm pretty sure there's, we can talk about that in a while. There's certainly also a real need for more midwives. And here you can just see the difference in maternal mortality ratio between 2007 and 2012 in different states, and it has gone down, but it is still very high in different places. Here you have one statistic about the antenatal care visits, and that actually I got from Sue Ellen, thank you very much. And you can also, again, see these huge differences across the subcontinent. There are places where you only have 20% of the population of the women having ANC care and the required amount. And then you have other places like Goa where it's almost 90%. So once more, big differences. Place of delivery, the number of institutional deliveries is rising, as I said, by about 15% between 2004 and 2014 due to the JSY program. But nevertheless, there are really big differences by location and by wealth. Yeah, you can see here the institutional delivery rates for different states, and they have gone up in some of those states. They have really gone from 30 to 85%, or from 19 to 36%, 63% in Bihar. So we're getting there, but I would also say that if the quality is bad, you don't know if the outcomes are necessarily better, and you don't know if women who try it once and they have a very bad experience, they might not try it again the next time around. So this is, these are real issues. And that's the slide I had before, and that's from 2014. What you can see here is how many people are delivering in the richest quintiles in private facilities, and you can also see then rural, urban, the differences and the different quintiles. And it gives you a pretty good impression. Urban populations, the richest quintile, 95%, 77% in private facilities, and then you have in the rural areas 58% of the poor people giving birth in health facilities, in government health facilities. So you have all those differences here. But now for the last, most important part. We talked about this. In my view, there's really a dual burden here in India of too little, too late, and too much, too soon. And so Alan covered cesarean section, so I'm not going into that. You saw the rates, how high they are already in the richer population and how little, so how low they still are in the poor population. So there is certainly need for more C-sections among the poorer population. And what I pointed out, apart from the medical issue, but Sue Ellen raised it as well, the cost. I mean, it's tremendous cost, and according also to WHO, this takes really away from universal health access, because this is money that is being used for something that should be used for something else. What I looked into more were the other interventions now that are happening and that are being routinely overused in India. And in my research, what I found, there's a list of things that are happening: pubic shaving, enema, induction and or augmentation of labor, infusions, antibiotic administration, episiotomy for first birth. There was a recent study. They found in 18 hospitals, 85.1% of 120,000 deliveries had also episiotomy for the first child, so almost as high as what we found in Thailand. Then the position for delivery and manual revision of the uterus. And I want to look at now, for the last few slides, really look at the issue of labor augmentation. That is a big issue in India. Many studies, and I looked at studies from North and South India, different places, they found routine use of oxytocin during particularly the second stage of labor for labor augmentation in almost 80% of cases. This data comes from the Lancet study, but it's supported by many community studies in different parts. And as you know, normally oxytocin should be given in the third stage of labor to prevent postpartum hemorrhage. And this, what really is interesting here, it happens in private facilities, in public facilities, and in home births. And in home births, it's as high, and it's usually unmonitored intrapartum oxytocin use. The mothers and the babies are not really being monitored after giving the oxytocin, and it's intramuscular administration, so it's not drip what it's supposed to be. And also, the oxytocin normally is not refrigerated. And in community studies, the practitioners, which are basically, they're not midwives, they're really village health workers or just pharmacists or other people, they didn't even know it had to be refrigerated. So this is what's happening a lot. And then I looked into the reasons why this is the case, and it's really interesting. There are a number of anthropological studies out there looking at from different places in India. There's a very high value placed on pain during labor in India. There's this thought that you have to basically, in order to have a fast birth and a good birth, you need to have strong labor pain, and that you get with the oxytocin. There were studies where the mothers-in-law were basically saying that nowadays the young women, they can't bear the pain that they used to be able to bear, and that this is a good way to get this pain fast and then get the baby out fast. There's also pressure perceived on both sides from practitioners and also from the community that this is the norm. This is what's regarded modern. That's what you do. Everybody does it, and if for a normal birth, it is normal now to get this injection. And the women were asking for it, but the practitioners also felt that this is okay to do. There's, as I said, a lack of knowledge regarding proper storage, dosage, and administration. And the other thing I found is that because of this push to go into facilities, they are often very overcrowded. The practitioners would like to get people out quickly again. And if you induce, well, not induce, but augment the labor, and it goes faster, then people are moving out faster again. So there was an interesting mix of cultural reasons, thoughts of what is modern childbirth, how should it look like, and then also systemic reasons, simply. So it is very, very, very prominent across the board. So my last slide here is to look a little bit at what can be done to address the overuse of these uterotonic drugs. And I'm sure we can discuss this a little bit later today. What different recommendations were in different studies was that, on the one hand, it needs to be included more in maternal and neonatal health campaigns, that misuse is really dangerous. It can lead to the death of the baby, it can lead to uterine rupture, to PPH, and it should not be done. That needs to go also really in the training of people. The quality of care needs to be improved, definitely. The guidelines need to be improved. Midwife training there was a big call for better training, more training and more midwives in general. And and then the other thing was, which I find very interesting, is that yes, there are studies now showing that this use of uterotonic drugs is very common. But what we don't necessarily know is how much does this use contribute to the still relatively high MMR, to neonatal mortality. So there haven't been any big studies to look at, are those two connected? We know it's not recommended, we know it's not good, but does it really have the bad outcomes that we assume it might have? So there's certainly a lot of need to do more research and to see whether these practices do actually contribute to mortality in India. All right, that was my part.
Thank you so much, Miriam. And we're really building up here a case, I think, which is very interesting. So can I ask you, Saraswati, then to give us the third jigsaw piece of this and look at the quality and what women say.
Good morning. I'm going to talk to you a little bit about, I'm going to close the circle because, of course, we can talk about these things from a public health standpoint or from clinician standpoint, from research, but what really matters is how it affects families, persons who give birth. And so I'm going to talk to you a little bit about the results of some emerging research that we have. There are several studies out there which are deemed to be person-centered research. I'm going to report the results to you from Changing Childbirth in BC, which was a provincial study we did in British Columbia, Canada, which reports the results of 3,400 care provider experiences across 3,167 women or families who gave birth. Also the Giving Voice to Mothers study, which was a study of maternity care experience and access to care and the experiences of care among communities of color and among women who chose to deliver in homes and birth centers. In the US, we have just closed the data collection for that, so my results that I'll report are preliminary. We've done that in a community-based participatory action way, and I'll explain that to you in a moment. Also, the maternity care experience study from Hungary, so that's a middle resource country now, with about 1,200 women. And then a look at, again, population level data in the US about access and integration of midwifery. We did a mapping study looking at access and the ability of midwives to practice to full scope across the United States, where we find that outcomes are very, very disparate, and we'll show you how those things connect. So there are some publications that give you the details about how we've developed the tools that I'm going to talk about. I won't go into a lot of the methods around those, but we have validated the tools that we use to measure these things, like concepts like autonomy and respect. So when I talk about community-based participatory action research, I'm not sure how many of you know what that means, but basically it means that researchers work in partnership with the people who are being studied and those people are the ones who direct how the questions are asked, what questions are asked, who they're asked to, and how the stories are told. So this is, I say this, I'm here just as a representative to all these amazing women who came out of the woods. We had so many participants, over 24. When we launched the study, which was an hour-long quantitative study in BC, in 24 hours we had 1,300 completed survey responses for this 1 hour long. So the value of doing participatory research is that when the questions are asked that are really important to the people who are being studied, they will participate. And that's what we found again and again and again. So we had the data that I'm going to report represents the work of these 4 work groups, which were women who experienced maternity care in the US in the last 5 years. In Canada, the women said, no, we don't want to just look at women, the single birth in the last 5 years, which as researchers was anxiety producing, because we always want to know what's our denominator and you know, which sample are we talking about. But the women said, but if we don't ask them to tell us about what was most important to them, we won't hear about differences in experiences they had in one setting versus another, or with one provider versus another. So we, in that case, I had to learn mixed effects analysis to control for the effects of one woman's data, you know, driving the outcomes, and we've done that. We also had many women from who experienced multiple barriers, so women who had been incarcerated, immigrants and refugees, women who lived on the street, women who lived below the poverty line or experienced other barriers, and women who may not have socioeconomic barriers, but were marginalized because of the place that they chose to give birth. And in the U.S. and in Canada, we were talking about home and, well, in Canada, it was home and hospital. In the U.S., it was home birth center and hospital. And in Hungary, it was home and hospital. So the study topics that these community members chose to study were access to care, preferences for care, experiences with maternity care, especially around decision-making, and knowledge of midwifery care. So I'm going to just talk to you a little bit about the decision-making portion of it, because when we talk about interventions and too much too soon, we need to understand who's making the decisions and what's driving the decisions. And when you ask women, this is data from the BC study, which had nearly 3,000 women responding to this question. We asked them to say, how important was it for them to lead the decisions? How important was it for them, for their providers to lead the decisions or to get input? And as you can see from this, I don't know if you can read it from back there, but 95% of women from all of these backgrounds said that it was very important or important to them, that very important or important to me that I lead the decisions about my pregnancy, birth, and baby care. Now, among that 95%, about half of those women also wanted the input of their providers. It was very important to me that my doctor or midwife guides the decision. So guiding the decision is different than leading, right? And so there was that overlap. But for at least more than half of the women who responded to that, that was not as important as them leading. So when we asked who made the decision, so in this population we had about a 40 to 50% C-section rate among the obstetrician clients, about a 23% rate among family physicians, and 15% among the midwives. And these were for all low-risk women. We did control for risk factors, et cetera. And that's another whole analysis, which we will see. But you can see from this that the orange and yellow are my maternity care provider recommended a C-section before I went into labor. My maternity care provider recommended a cesarean when I was in labor. The bulk of the decision is being driven by providers. So understanding that, the surveys had been populated with some validated tools that the communities had adapted to measure what they wanted to. And some of them were about respectful care and some of them were about autonomy. And we actually took one of those sets of questions and did the psychometrics to create a new measure, which we call the Mother's Autonomy and Decision-Making Scale. And on this scale, the participant, the person who's experienced pregnancy care, will answer certain questions. My doctor or midwife asked me how involved in decision-making I wanted to be. My doctor or midwife told me that there are different options for my maternity care. My doctor or midwife, and in this case, they could actually populate. They could answer the question separately for doctors if they had a midwife also. So we knew who they were talking about. Just for the purposes of the the slide, I've presented it this way. My doctor or midwife explained the advantages or disadvantages of the maternity care options. My doctor or midwife helped me to understand all the information. And then these were the three things that the women added that said, no one is asking us whether we had enough time to consider our options. Nobody's asking me whether I was able to choose what I wanted and whether my choices were respected. So those things were added, and we revalidated the scale. And then we also have a much larger scale. It's about 14 items, but it talks about overall, while making decisions during my pregnancy and birth, I felt comfortable asking questions. I felt comfortable declining care. I felt comfortable accepting the options for care that my provider recommended. I chose the care options I received. I felt that I was treated poorly by my maternity care provider because, and several different options between race, sexual orientation, type of health insurance, and how did that affect their behavior? I held back from asking questions or discussing my concerns because my maternity care provider seemed rushed. I thought my maternity care provider might think I was being difficult. I felt discriminated against. Now, some of the data I'm going to present to you, where we started out by just looking at simple descriptive data, how people were answering these individual questions, and we realized that they all hung together. We validated it as a full scale to measure this concept of respect. So you'll see how that works. The one I want to point out to you, though, in this scale is that there is one item which says, I felt coerced into accepting options that my provider suggested. Now, when that was suggested as an item to include, I was uncomfortable as a provider. I was like, coerced, really? Will people understand what that means? Will they use that? That seems awful strong. We want to have an even number of positive and negative, but there was a very strong response from all across North America that was the word that had to be used. And in fact, the data show that was an important concept to as I will show you. So overall, what we found was that what was more important than whether or not women had a C-section or an induction or augmentation was whether or not they felt pressured. So we did what's called a mixed effects analysis and a regression analysis, where we looked at what's driving the sense of respect or lack of autonomy when we use the scale scores as an outcome measure. So the Madam scores are autonomy, the Mori scores are respect. So what makes the scores go up, where they have more autonomy or feel more respect, and what makes them go down? And we thought maybe it's just that they're unhappy that they had the C-section or that they had an induction. And what we found actually is that it wasn't whether or not they had the intervention, it was whether or not they felt involved in decision-making. It was whether or not they felt pushed into it, coerced into it, whether or not they felt pressured. So out of all these samples, 2 in 5 women felt pressured to have the C-section, 38%. And Mori scores or respect scores went up. They did go up. If you had a C-section, it was less, and with an instrumental vaginal delivery, like forceps or vacuum, it was a little bit better. But of course, the scores were highest with spontaneous vaginal delivery. But I should mention that some of these women were being pressured into having these interventions, and some of them declined those. And they still felt disrespected, even though they had the spontaneous vaginal delivery. They felt overall that they were disrespected. 54% of women felt pressured to have an induction. And in the US, the induction rates were at 40%. So poor treatment came alongside that. So all these measures of poor treatment and the fears of poor treatment regardless of provider type, equaled decreased respect, decreased autonomy. Again, I'm talking about those scale scores. When they had a difference of opinion with their providers, women held back their questions if they wanted different care because they were worried about this poor treatment. And they also had lower Madam and Mori scores. In Hungary, when we tried to look at this more carefully, I'm sorry, this is a small slide for you, but I'll interpret it for you. In Hungary, this is just one of the outcomes. This is episiotomy. So we heard in middle resource countries that we have high rates of episiotomy. In Hungary, it's a 70% rate in our sample. And It's 70% of people who had the episiotomy and 63% of them who did not give consent for that, and it was done anyway, done without their consent. So when we look at socioeconomic status and race, this is from the Giving Voice to Mothers study, and we know, as we've talked about, there are huge disparities by race, and we've drilled down and we've looked at this, and we see that if you're a woman of color and a Medicaid recipient, your sense of autonomy and respect, that's autonomy on the left and respect on the right, the far left, you can see that the lowest scores came from if you were poor, if you were publicly paid, and you were a woman of color, your experience of autonomy and respect was the worst. We also found that provider type influences autonomy. And we drilled down in this. These are uncomfortable and dangerous data to say. And is it just about whether or not you're a doctor or midwife? And I'm a midwife, leading this team. I'm working with many physicians and other professionals on my team. And it's not about it. Is it how we're socialized? Is it what's going on here? So we looked a little further. We did find that the respect scores were lower with hospital births than with home births, and that midwifery clients consistently reported more respectful treatment wherever they were. And we think that it has something to do with time, because we found that there were higher MADAM scores. We asked them, actually, they were asked, how long did you have in a prenatal appointment? How long did you have when these discussions happened? And with more time, they had higher autonomy scores, with more time to process information. When we looked at this in our mapping study, and the mapping study is much more complex, but just a taste of it just to show you, if you look at these maps, the dark purple are the states where midwives are integrated across birth settings, and they are more likely to be able to practice to their full scope. The integration scores run the highest integration score you can get is 100, and I have to say that in the US, the highest score we got was 61, so we're not a highly integrated state. However, if you look at the difference, you'll see that the white and paler states are where there aren't as much integration. And if you look at the outlines, and it may be hard for you to see that there, but I'm happy to share these, the red outlines are where we have the highest C-section rates, the lowest spontaneous vaginal delivery, the highest and the lowest vaginal birth after cesarean. The green ones are the high spontaneous vaginal delivery and C-section. We've looked at breastfeeding, induction, neonatal mortality, many outcomes that are, again, publicly available data through the CDC. And these correlations are very, very, very strong. So we know that integration density, just whether or not there are midwives in your community, and this is true, and I'm talking about Canada, US, and Hungary, that access density increases interventions and reduces the ability to be successful with breastfeeding, increases if you don't have access. The correlations between neonatal mortality, and especially in those states where we have high percentage of black births being reported, are there. So I'm almost done here. I just want to leave you with a couple of quotes. We have some qualitative data too, and this is what the women say. They made an anatomy scan in the 3rd trimester sound like a good idea while I was trying to decide if I wanted to decline because of my fear of them wanting to tell me my baby was big and wanting to induce. I didn't decline the scan, and that's what happened. The maternal fetal medicine doctor told me I was going to be induced at 39 weeks. No risk no talk of risks or alternatives. Told me, then proceeded to tell me that I wouldn't want my baby to die by waiting. At my most recent birth, I had a nurse tell me when I said I wanted to go home and come back to try the induction the next day that she had a patient do that, and the baby was stillborn. She did this while I was alone in the room and my husband was returning with my parents. My midwife always seems rushed, and I felt stupid for asking questions. She told me I was anxious. One doctor in particular was awful. He bullied me, tried scare tactics, ganged up on me by showing up with a team of 4 to convince me to do what he wanted. It made my labor unnecessarily stressful. I will avoid the hospital at all costs in any future pregnancy unless absolutely necessary. So that's, I think the parting thing is that so Ellen and I just came back from the Human Rights and Childbirth Conference in India. These are global issues. This is not about India or Hungary or Sub-Saharan Africa. This is a global problem. Women are feeling disrespected. In India, when I was just there, the women were getting up, they were talking about it, the midwives were talking about it, that they may have these cash incentives to go into the hospital, but when they show up, the orderlies say, well, you have the cash, you know, why don't you buy yourself your own food? Why don't you get your own induction? Why don't you pay the doctor? And the governments have not increased the number of physicians, nurses, orderlies, or midwives. And so they're massively overworked and under-resourced, and they're exhausted. So they take that exhaustion out on the women, and then the women don't come back. So it's happening all over the world. These kinds of disrespectful behaviors, which then connect with outcomes. And institutional birth has not been shown to be the answer, as you can see in our very upperly mobile saying that it's not about, it's about skilled attendance and respectful care. It's not in Sri Lanka, where they invested in upskilling community health workers and midwives. They actually brought maternal mortality down. And to answer the question is that we have these huge numbers of women going into hospitals with 3 to a bed and overcrowded hospitals in terrible conditions, and we have not improved the outcomes. That has not worked. They've tried that. They need to try something else. Thank you.
Thank you so much to all 3 presenters. I think we're all full of thoughts and questions and eager to discuss. Let me just start by one thing that came to mind, because what you have shown is that this is global. The need for quality, the need for not over-interventions in childbirth, that's global. The need for respectful care is global. And then, at the same time, you have countries where the resources are scarce and the number of health workers are few. And sometimes the training is not up to the level. And so you have, if I was now to put myself in a policymaker's shoes and say, okay, so I see this problem. I do not have the right number of healthcare workers to really be there with women during their childbirth. The hospitals are not well equipped. So where should I start? What is the most important thing for my health system to develop into a more humane place for women? Because I do think that we need to start, even though there may be a lot of opposition to saying, well, the resources are so much bigger in the north, and of course women can choose when they have education, but I do not think that that is correct. So if I let you if we start with Saraswati, if you would just have some advice to that policymaker, what would that be?
Well, I think that the policies, incentives, whether they are financial incentives around insurance and coverage, need to match the evidence, and that, in fact, that we need to incentivize. We know, so women don't feel like they're the ones in the driver's seat. We know that there's a lot of data to show in many other healthcare fields that provider attitudes drive women's or families, people's choices of all kinds of options, the cancer drug, the heart medicine, and maternity care options. And so there needs to be, I think, a multi-pronged approach. The attitudes research shows that basic education matters, so that how physicians, nurses, midwives are trained during the training programs, and whether they're exposed to physiologic birth, whether they're exposed to each other, interprofessional opportunities for education, and approaching, valuing and elevating things like shared decision-making and person-centered care, I think, is a very important initiative. But person-centered care and research, it's a nice phrase, but it has to be implemented in a very practical way, I think. And I think then, other than that, having a human rights lens, having women and having public information campaigns about, just as they do for many drug opportunities or things like that, is that women don't know what their rights are, and I think that we need to also educate the public about how too much is not always better.
Thank you. Miriam, in your case, you talked about India, and
I think, one thing that I also came across, what I didn't say here, what's important also, especially with the oxytocin use, there's a policy, you know that the hospitals cannot accommodate all the people. So home births will be a big part of the Indian experience in the years to come. So it's not feasible to have everyone in a facility, and not necessary either, as we know. One policy, though, is now the thought of, okay, how do we prevent PPH in home settings? And we give basically the injectables or the oxytocin to the health workers in the communities. But that might make this problem worse, because it's more accessible even, and they're supposed to give it in the third stage of labor, but then they give it before that. So I think very good, trying on in the community to have education and to really work with community health workers more. Midwifery training would be very, very important, to try to increase the knowledge on those issues. Also, in the families, in the communities, not just for the providers, but that women, the education that you say, that women also know these things are not necessarily just good and modern, but there are other options. But it's very hard to achieve. I think, even here, I'm a mother of 3, and if I think back to my experience, I don't think I was asked a lot of things. And I had preeclampsia the first time around, and I only found out a couple of days before the due date. And my doctor basically said, I was in the hospital, and he said, so, what do you think about having your baby in 45 minutes? I think we should do a C-section, he said. And what do I know at that moment? I knew I was kind of sick, and I didn't really know, and he didn't present any alternatives. And my husband and I were looking at each other and said, okay, I guess that's it then. And it didn't feel terrible at that point, but in retrospect, I think, well, there might have been other options, and I wasn't asked. And then with the second birth, it was assumed. Well, you had a C-section the first time. I think it's the safest, my doctor said, to do it again. And they did it again. And there wasn't a big discussion about VBAC or anything. So I think, as you presented, it's here as well. It's not just in India or in other parts of the world. And so I think there should be more education on the patient side, on the mother's side as well. And that's hard to achieve, but I think even we don't know it, and we are highly educated. We don't speak up necessarily, and so to expect it from everyone around the world to do that is very hard. Yeah.
But that could be something then for community health workers, really, to empower women to know more about their bodies and health. So from the global perspective, and with all that you have, so here I am, this politician.
The first thing I might ask, if I were being impolitic, would be, well, what's your budget for military and what's your budget for health? Probably wouldn't get me anywhere, but it's worth saying when you come up against somebody who says we don't have enough hospitals and we don't have enough respect for it. Yeah, it's just terrible. Okay, so I can't say anything that's really a lot different. I think basic education of women about their rights is totally crucial and is a good foundation. I think that the advantages we sometimes saw in birthing in the U.S. in the 70s and 80s, which seems to have dissipated, really came from women's knowledge of their bodies and listening to their bodies and understanding that they did have rights and they could make demands. Different than education is the training of providers. And since the paper that we worked on was so much about providers' behaviors, we looked in a lot how difficult it is to change behaviors. And the behaviors that we want to change, we have to model and we have to practice if that's not what's basic in the training that's currently going on. And then I also think respecting medical students, nursing students, and healthcare workers in general. In many places, people, the women especially, are oppressed, and they will turn and oppress their sisters who are laboring. So these are not easy things. They're not easy things. The other thing about behavior change has to do with differences. And what I saw in this study that we did in looking over, what outcomes are and what practices are, is that guidelines, as we discussed them, that was our topic, were so totally inadequate to improve health outcomes and health care and women's feelings of autonomy. And that what we saw was anytime there were differences, a difference in ethnicity, color, migrant status, anytime there are differences between providers and women birthing, that there was discrimination, that there was inequity in the application of these guidelines. This is even in the Northern European countries that get a lot of kudos for having midwives and having universal health access. So those things aren't enough without the respect and the dignity and the recognition on the care of providers that every woman has a right to this respect and dignity. So I believe I agree with you. It's a human rights lens that everybody needs to take.
Thank you. So now I turn to the floor. I know that there are two mics standing up, ready to go where they need to be taken. Please.
Hello, I want to thank all of the panelists for this fascinating review and new perspective and emerging guidelines in this community of practice that definitely needs to be further empowered. I'm Lori Romanzi, I'm with Engender Health. I run a fistula project, but before I did that, I trained in OBGYN. And I have to say, Miriam, it was really interesting to see this common list of mandatory interventions in India, because I can tell you in 1988 in Brooklyn, that list was heavily enforced. And those of us who spoke up against the uniform application of episiotomy and shaving and high, hot, and hell of a lot enemas, we suffered. But I want to throw out a couple of considerations for this panel, not to play devil's advocate, but to look through a slightly different facet of this phenomenon. And that is, as women are empowered, especially through education and increased socioeconomic status, we know that many of them will demand cesarean as easier, as possibly safer. My Indian colleagues tell me that there's something called cesarean by horoscope. Are you familiar with that? And these calls for demanding cesarean by horoscope often come at 3 in the morning. So it's not just surgeons or OBGYNs trying to make more money. That's part of it. But it's also the patient. Part of the patient education has to be, even if you have a lot of money and you have a lot of power, to go in and coerce your provider to give you a cesarean or else needs to be part of the messaging, I think, especially as low-income countries move to low-middle-income status and this phenomenon starts to kick in. And the analogy to malnutrition seems very evident, where you either have overnutrition or undernutrition, and how do you strike the balance? And I think that this panel, probably more than any other, could give us some lessons by scanning the environment where the balance is better struck, where you do have high integration of midwives, where you do have universal health coverage, where you do have a homogeneous society, and where the clinicians not only are held to a standard with consequences if they don't, but they can also lean on that standard when they're pressured to do a cesarean that they don't think is indicated. And that happens everywhere.
I'd like to know what country that is. I don't think it exists anymore.
No?
No. We're in a diverse society all over the world. I live in Canada, which I think has one of the, more progressive healthcare systems. We've got, I am, as a midwife, I am funded to, in fact, I'm not only funded, but I am regulated to provide informed choice discussions, and my funding allows me the time to engage in that. but we still see it in Canada, especially across communities of color and immigrants. There are huge differences. There are power things that happen. I think what you're talking about, though, is a lack of what I was talking about educating the public was not just that it's their right to say no, because we did find in our studies in North America that there isn't a lot of non-consented care. There is some. And in Hungary, interestingly, there is non-consented care, but most of those women didn't know they could refuse, and most of them didn't know it wasn't necessary. They were convinced by their providers that it was necessary, including with the C-sections, and they did not have as low respect scores because they felt they were convinced that, their lives were being saved. And so I think that the education piece is actually about what we know now about physiologic birth and the benefits, the health benefits to mothers and babies when women deliver physiologically, assuming that they don't have a reason that we need. There's always an appropriate level of intervention. It's not home birth at all costs. It's not vaginal birth at all costs. And that's a really important distinction. But it is about this, what's the balance? We may never know what the true optimal cesarean rate is, and that may be very also access and country specific. But women in rural British Columbia that are 7 hours away from any facility will say to them, it's a greater risk to leave their Aboriginal communities. It's a greater risk to be separated from and wonder who's going to look after their children when they're flown out and sit in a hotel for 5 weeks waiting for the modern technology. That they feel, and then they have to pay for themselves to go back. And so that puts the entire family at risk, and that's not a risk they're willing to take. So I think helping medical students, nursing students, midwifery students, the people who are talking to them understand the difference between absolute and relative risk, and then how to contextualize it within that woman's life, and helping her to understand really how likely is it that your baby will die? Why is this being said so much to women? And is 1 in 1,000 an acceptable risk when you look at all those other things? And that's true of induction, episiotomy, all of those things. I think it is about education about physiology, and when physiology is actually more brilliant than what we have brought to the table.
Okay, so we have a couple of...
We did not find, by the way, elective C-section. I mean, we asked the question, and nobody was saying, we asked for it. And this is, in a highly educated place. So.
Thank you very much for your presentations this morning. It was very informative. I'm a home birth midwife in Washington, D.C. And
please introduce yourself.
Oh, I'm Claudia Booker, sorry. I'm Claudia Booker. And in this middle income country that I live in, the differences between respectful care, compassionate care, kind care among care providers and their ability to stay current on evidence-based information is a problem that I see fairly often. I also see fairly often, because America is becoming a country of women and families of colors and not white families anymore, that our society is going to have to change how we look at birth in many different perspectives. People will not be looking like many of you in the room anymore, if they still do at all. And we have to keep that really in mind, that when we walk into providing care, that we are culturally specific, culturally validating, culturally welcoming to our clients and to our patients. Because the power dynamics that people who are new arrivals, meaning people who've gotten here in the last 50 years versus in the last 10,000 years, must be taken into consideration. Many, many new arrivals are coming from places where the power dynamics of speaking up for yourself is a different thing than we have here. And our arrivals who came not on the Mayflower also are very, very much influenced by the white coat syndrome and the fear of child protective services being used against them. So we're really going to have to, in this country, really spend time at looking at who the families are that we are taking care of. What are the specific cultural needs of those families? How important, as Sarah's wife, being in the front seat and driving the car, letting our clients drive the car with us giving them the map to show them the way for various options. We must really, really look at that if we're going to make a change. The fact that birth for Black women in America is getting worse is astounding to me every day, that it's getting worse for my women and not better. And we must keep in mind that if we can improve outcomes for the most fragile, we will exponentially improve birth for everyone globally.
Thank you so much, and I'll take that as a comment and really just comment from my side that this is exactly what we're trying to look at when we look at the Sustainable Development Goals, to leave no one behind and to reach the furthest behind first. And this is so important, so thank you for that. Shall we take one more and then I'll let the panel come in.
Hi, thank you. This has been very interesting. I'm Linda Harmon, Executive Director with Lamaze International, and really feel excited and interested in how childbirth education can play a part in helping to inform and change some of the statistics that we're hearing. It's not?
No,
yeah, okay. At any rate, I'd be curious if any of the research that you've done takes a look at the education that women have had, maybe independent of their care provider, because sometimes, as we've heard, the care provider isn't necessarily unbiased as to the recommendations or the coercion or pressure that might be applied. So for us, I know that this is an area we feel that needs more research, and it's a very difficult area to look at, but one that we really want to partner with other people on because we think we can have an impact in improving care.
Thank you. And can I ask, is there anyone else who has a question that relates to educating the public, so that we can have that now and then I'll leave to the panel? Maybe some other angle on that? Otherwise? Anyone of you would like to say something?
I'm unaware, so I don't know if anybody else is aware of any efforts that are currently going on for that kind of research.
We did ask women. It was, Eugene de Klerk is one of my co-investigators on these projects, and he's a brilliant public health epidemiologist now, but started his life as a childbirth educator. So almost every study that he does around maternity care experience, make sure that you ask. And so we did ask, did you take childbirth education classes? Did you have a doula? Where did you get your education? And it makes a difference. I don't want to report that we're still in the process of analyzing that, but it appears to make a difference.
Maybe not in terms of research, but what I've seen that there are more programs out there that are also using, for instance, social media, using mobile technologies. You're aware of the programs in India, Mama programs, and so on, that use, for instance, cell phones to inform pregnant women. Basically every week or of their pregnancy, they can get messages about what is happening in their body, what the situation, how big is the baby, what should you do as a becoming mom. And so I think these are, apart from the good examples like Sri Lanka, and where you have this outreach, or also in Ethiopia, they're making huge efforts with 35,000 health workers over the last years going in the villages and so on. But I think this mobile technology could be very interesting because especially in urban areas, in everywhere, Asia and Africa, people have cell phones, and that gives you, I think, some autonomy if this comes not from your doctor necessarily, but if it comes from a good NGO, from other community organizations and so on, that give you a second opinion, basically, or more information about what is happening in your body and what is happening with the baby and what could be options.
There's a lot of research. It's a great point, because there is a lot of, that's the new place where people are doing research about what the impact of social media, and it is very accessible in low resource countries. Everybody has cell phones, so.
I wanted to make one comment on Ethiopia. I know I'm the moderator, but there was something, if that's all right, and then I will not forget that you raised your hand. I think the health extension workers have been instrumental in Ethiopia in some ways on getting women to antenatal care in contraceptive use and so forth. What they have not been successful is in maternity care. And I think why Ethiopia is successful is because they have parallelly invested in midwifery to a very large extent. So they have gone in a couple of years, 4 years, from 1,000 midwives to 7,000, now moving towards 9,000 midwives. Very few still in a huge country, but I think that is the way to go forward, to really have the most experienced workforce at the furthest end.
But the scope of practice and the model of practice for midwives is very, very important too, because we've seen that they're very different ones in the U.S., and that affects their ability to practice to this ability according to the evidence. And we know in Chile there are 7,000 midwives. They do most of the births, and they're running in public and private hospitals, but they do not feel empowered at all. And they've actually they're inviting people like me to come and teach the midwives about physiologic birth, because that's not how they've been socialized to practice. So
No.
it is also...
I fully agree. Ethiopia has done that, but there are countries, as you say. Now, let us not talk up here only. Please
Simin Wahdat, thank you so much for the presentation. It was really very informative, especially for me that I'm not involved in the medical or... my question is, are there models that other communities might have used in public awareness that could be used as a model for other countries? And also, what about engaging men? Because in most countries like Afghanistan, husbands will be the one who make the decisions, if you have any experience on it.
I think there are a growing number of emphasis on men and bringing men into the discussion and helping men to understand and see that there is a place for men, and not just in saying yes or no, you can go to the hospital and making those kinds of decisions, but being alongside women during pregnancy and childbirth. And so there are organizations and NGOs that are welcoming men to the bed, if not the table. The first part of your question? Oh, yeah. I don't know. Do you have some good models?
Models for public education?
Oh.
I think everybody's struggling with that, right? Health messaging is a it's a difficult thing, and it's fast evolving because of the social media. But I think we have to harness it. I think we have to partner with people who are brilliant at it, like Google and Gates and IT specialists to do these kinds of messaging around evidence-based care.
Yes, there we have someone there.
Thanks, everyone. I'm Tina Johnson. I'm from the American College of Nurse Midwives. And I have a question about, back to your topic of time and women needing time and the ability to understand what's happening and to learn. How do we incentivize that? How do we get policies to change so that wonderful midwives working in busy practices are not incentivized to see 25 patients in a day, and that's the only way they're going to meet productivity mandates? How do we get the country, especially in the U.S., to understand the value of that concept and to really practice, to allow people to practice in a way that supports women? Because I think that can be a real problem in many communities.
Well, I keep feeling like the questions people are asking are very, very difficult. These are not simple. There are no simple shortcuts to giving more time. I mean, in all the medical fields, nursing fields, there's a time crunch, and people are not paid very often to do counseling, preparing someone for dying. The time that we need to take with people, we providers, is not compensated. And making those kinds of changes in our current situation seems very daunting rather than becoming more easy? That's my response.
I will tell you that it has been done in Canada, and that's what I think absolutely has made the difference. And when that we're going to start comparing the data from the different contexts. But so I touched on it, but I'll explain how it works. That in Canada, they brought midwifery, professional midwifery, and only in 1993 in Ontario, 1998 in BC, and just this past year in New Brunswick. It's still coming, right? So, but the model that they've put in every province is a model that requires continuity of care and these principles of things like informed choice and decision-making and stuff. And in order to do that, the physicians are all paid on a fee-for-service model, and so that incentivizes, seeing more. And when there's a shortage, also it incentivizes, trying to get more people in, and have shorter appointments. But we're paid on a course of care, and so and we're capped in the number of people we can take per year. And so actually, there's no incentive to move people through. We get a decent salary, but and they did that these were ministry decisions. They were very much cost associated, and we've now shown that with cost effectiveness of midwifery care, cost effectiveness of birthplace. There's a lot of data to show the cost effectiveness of investing in those counseling sessions, in investing in more time for discussion, for informed decision-making, investing in time in relationship-based care. The data are there that it actually ultimately reduces costs, because you will then reduce C-sections, reduce readmissions, reduce morbidity. So it is not a zero-sum game. It can be done, and there are models that exist at least for that. I don't know about public education, but I think it can be done.
I think in the U.S. right now, at least, because that's what you're asking about, I think that there are some models like the Kaiser Permanente model. I don't know how it functions here in D.C., although I think it is here. But in California, they have now, it's totally evidence-based care, and they're always re-educating their current providers. They have really well-treated, well-respected providers. You go to the emergency room and you see somebody that you saw 10 years before, and they say, yeah, I'm still here. And most people at Kaiser don't change jobs. So there's that respect piece. I think the other thing there is salaries. The doctors are salaried. They're not fee-for-service. So that piece of the model. And while cost is important, making sure nothing bad happens to people is very, very important. So they're really alert to the kinds of complications that are so costly.
And can I take the example from Sweden this time, and saying that what we have done is built it into the ANC, so that the time with the midwife when you come for your antenatal checkup is towards the end of the pregnancy longer, and you do discuss how they want to see their birth and where they want to go, and then of course the realities hit when they get there, and it's overcrowded and so on, but the preparation time is given. We have also done a special counseling for women who are very afraid of vaginal births, where they get to see a midwife and talk about their fears and see whether they can change their mind and not go into C-section. So there are different models, but they are time-consuming. And I keep thinking about the low-income countries, and where you're one midwife and you have this long, long line of women just waiting to see you, and they may have walked for 4 days. So there are great disparities in what you can manage.
Yeah, that's where we need to incentivize, instead of maybe incentivize, community health workers to be able to provide that first-line education.
Mm.
Right, and things need to be so context-specific. That's the other problem with trying to answer questions, what can be done, what should be done. Nothing can be done without going into the communities, as various as they are, if you want to make a policy change and investigating what's important to the people who are affected by that policy.
Other comments, thoughts you had? We talked a lot about the disparity and the divergence. We talked about the women's need to have their voices heard. We talked about who decides. Reflections, yes?
Hi, I'm Megan Parker. I work here at the Wilson Center with Roger Mark. and Francesca. I had a question about the education piece of it, talking about the challenges of helping women understand the different levels of risks and helping to make their decisions. One of the things I found when I was pregnant is that it's very hard to learn all this sort of in that compressed time frame when you're dealing with a lot of new information. And also, you know, it's a challenging time hormonally, mentally. You're not necessarily like in the best space for really being able to measure risk, because your assessment of risk is challenged a bit, I think, by these new responsibilities. Why don't we talk more about these things before women are pregnant? You know, the last time I had sex ed before I was pregnant was, 30 years between where I had my kid. No, 25 years, gosh. But there was a big gap, right? A lot changes. We don't have any process in this country, and hopefully it's different in other places, for talking about pregnancy and birth with women who are not pregnant.
Yeah, I agree. I think that's a very good point, because a lot of the things you only find out once it happens to you. And many women here who have children in the room and who have given birth and who had newborns, it's amazing how much you need to learn and how difficult it is and how many things no one ever talked to you about before. How difficult nursing can be and all those issues. And my native country is Germany, and we have a similar system to Sweden. And I moved here when I was with my first child 8 months pregnant. So I had to switch doctor, and I was totally surprised to learn that I wouldn't have a doctor and a midwife. And I was also surprised to learn that no one would ever come to my home after the birth, because in Germany it's standard. You have a doctor and a midwife, and the midwife comes to your home every day after birth to see whether you're okay, to see whether you can nurse and everything. And I had big trouble, so I had to trek all over town to find, help, basically, with a newborn after a C-section. Not very much fun. And so there are different things that, you were asking about ideal countries. I don't think there is one, as you said, but there are certainly things that can be done better than in the US, I would say. And on the other hand, also low-income countries. And when I teach my class at Georgetown, we look at, for instance, Sri Lanka as a positive example of a country that has really managed to do pretty well with lower resources and having a very comprehensive, good maternal health program. Within India, and I showed the slides, Kerala has a very good program. They have comparatively very low maternal mortality and neonatal mortality, because they have adopted these more community-based, midwifery-based programs. So I think, there's no ideal place in the world, but there are certainly better places and worse places to become a mom. And so I think we can still learn from these places and try to adopt and copy and
Right. Well, addressing your question about being educated before you walk into the labor room, which I'm assuming you're asking that question from a U.S. perspective, I think
even before pregnancy, I think was the question.
Okay, even before pregnancy, but I think that may happen. You may get better sex education, but how often can you take it when there's a big gap between when you take it? But I think our childbirth education of various kinds provide a lot of that information. Having a doula with you is able to make a pause and have a discussion about what your options and choices might be, a doula who's independent and knowledgeable. Lactation consultants are available. I think in some high resource places you have those options, or you can find those options. Financing those options is a problem. Everybody's going to pay for these services out of their pocket mostly. So it's not a universal answer. But I think we shouldn't believe that there's nothing that could be done. And if we were in a system where we had a single payer that was working on evidence, then we would have some of these things built into care.
Access, two things I'm going to say is that for people, there's this proliferation of something called decision aids, which are online decision aids that people can do in their own homes and that help them actually sort through what the evidence says and and it asks them about their own values and helps them to understand what might fit their values, because not everybody will choose the same thing. And those are existing for all kinds of medical fields and are emerging in maternity care. So I think that can help, and that those could be adaptable to other countries and other languages and contexts as well. So that might be helpful. As far as the education generally of the public about, my answer is sort of the same, is that if we educate our children and our young people that the human body is amazing and has many capabilities, and if we help them to relate to things like a long labor can be like running a marathon, that if you have, they understand things like endorphins and adrenaline and those kinds of contexts, and if you can relate it to that, and that's actually no different. You can also, get a high and get benefits from this when you're doing this other type of physical activity. Taking away, sexuality and sex education is often not, and certainly in the country of my family's origin, often not really discussed. But when gender equality improves and you start to be able to say those things, not just about human rights, but about, what you're able to do and what your body will do for you, and why it's good, then I think your point is well taken. It needs to be the whole ball of wax, right? All of us need to trust more. But I think the elephant in the room here is the liability piece, if you talk about risk. And the problem is that if people, the previous question who asked about people in India asking for C-sections and horoscope delivery, et cetera, I think they're doing that in the absence of this kind of information about what the consequences are, about how difficult it will. They're thinking about the pain of the day of labor, but not the 2 weeks of pain from the surgery, or how difficult it will be to breastfeed and how it will impact their future life or their future ability to have a normal delivery. And those things are not part of the informed choice discussions, right? And that's why things like decision aids. But it's also important for physicians to understand those things, because those are health risks that they are, that we are all contributing to when these things happen. And liability in this concept of risk and a risk-averse society is, hand in hand with it happened to me. This is the U.S. This shouldn't happen, and I'm going to sue. You should have done something. Whereas sometimes with physiology, there isn't something to do. There's a natural progression, right? And that's something that I think that is really valuable to have public education about.
Where you're going, I mean, we keep reflecting back on, what's going wrong in the U.S., where we have so much money, where we had so much money. But it's just an interesting point that you can have something like liability insurance for obstetricians, which is so high, and one of the things why they have to make so much money so they can see so many patients, so they can pay their malpractice, and why they have little patience for, the full physiological childbirth, because they're driven by this. In places that have a no-fault kind of malpractice, that makes a difference, and outcomes are better and C-sections are lower. But then it goes into, why does a country have this? Why does a country have to have malpractice when you don't have universal health care and you have private costs that are so high? If I, as a midwife, delivered a baby and that baby, for whatever reason, was damaged, the family is going to be needing hundreds and hundreds of thousands of dollars for the care of that child for as long as it lives. And so my responsibility is to have malpractice to cover that. But if there was a no-fault kind of a law and there was a fund, then that could make a difference too. So I know we're getting off onto a lot of things.
And I think we need to wrap up. But I would like, before I give the floor to Roger Mark, to say some concluding words. I think that what this shows is that this discussion expands as we go into it. And that's just to show the complexity of these issues and the diversity and disparities that you talked about from the start. And I think that many of the things that we have now talked about that is true for the more developed countries of the world, we do not want to see that those will be exported to the developing world. We really want to see that we find ways of averting that. I can see in Sweden how much the empowerment, in one sense, of young women to say that they need pain relief during childbirth has not empowered them to go through childbirth in a way where they can feel empowered, and will then set in motion a lot of complications that relate to having anesthesia or an analgesia. So these are also things that we haven't been able to discuss today, but I think we go away with a lot of thoughts in our minds, and I remember especially the human rights lens, the decision making, give it to women, education, both for the public and for the practitioners, is extremely important. And by that, Roger Mark, please.
Thank you very much, Annika. And I think I agree with you. We come away with so many thoughts in our minds. I think through our discussion today, we really started by looking at too much too soon and having a sense of what's the lay of the land. I think we had a really good sense of what's happening on the ground and how we can learn from that. And I think our framing that we heard from Annika, that we're losing sight of the normal process, forgetting it, not trusting it, fearing it, was an important context in which we started our discussion today. We had, I thought, a really good discussion about when care becomes overly medicalized, that it doesn't give rise to opportunities for dignity or respect or autonomy. And we saw that reflected across different economic sectors and what that means. We also had a very good discussion about the why. We talked a little bit about the cultural reasons behind some of what we're seeing. What are some of the systemic reasons? And I think a really good conclusion that this is really a global problem. We have it in the United States, in Canada, in Hungary, in India, but globally, we're seeing a lot of this present, and it really is a critical issue that we see reflected across differences. And this idea of differences in clients, but who's providing the services, geographic access, health interventions, public health infrastructure, capacity, communities of color, whether clients are publicly funded. So I think a really important element of that discussion came out today. I was really also struck by the idea of representation. Who is speaking? I think when Annika started, she said, I'm standing here as someone who's representing the global community, a midwife and a mother. You know, the few guys in the room, we stand here also as members of the global community, but as husbands and as fathers, and for me as the father of sons. And I think, how do I convey our dialogue today onto them, and what is their responsibility? So I think that's also a very important dimension for us. I was also very much struck that we said, even among us, and we are well educated, even we very often don't speak up ourselves. So this is really a problem that we also face. And we also spoke about, as we see economic shifts from low income to middle income, what does that mean in terms of demand for services? How do we capture that? What does that mean in terms of representation? We also spoke about representing the maternal health workforce. What about the providers, medical students? What does it mean? How do we get their perspective into this conversation? So I think really, really rich. We spoke a lot about the difficulties. Sue Ellen said, gosh, the questions people are asking, and they're so very difficult. But at the same time, she also said it's very context specific. So we have these very difficult questions, but we don't have very generalized or generalizable answers to these important questions. And those are questions around respect, autonomy, and education. How do we look at absolute and relative risk, and what does that mean? We talked about having culturally specific, validating, and welcoming approaches. I think this is what Claudia's point, I think a really good point, and we think about how this ties into the SDGs and these global processes that we are implementing now. A call to look at models of public education. Still struggling with that, we don't know. I was glad to have a comment about how can we better engage men. Don't leave us out of the equation. I want to bring us to the beds and to the table. Also, what does it mean in terms of the working environment, the context, quality of care, and productivity mandates? How do we address that fundamental challenge? And what does it mean for the liability piece that we mentioned? And how do we move to measuring the long-term reduction of costs? And it's interesting for me when I meet many young women who work with us here, with whom we collaborate, I get two questions from them. When we have this kind of discussion, some of them say, this sounds really painful, I'm not going to have children. So we want to make sure that we can convey, the fuller picture, but also many of the young women and men who are interested in these issues want to know, well, what is the career path forward? How can I have a career in this space if there's so many challenges and difficulties? So I was glad in today's discussion we also spoke about change that is coming, change that is happening. We talked about redefining labor, truly informed consent, midwifery care and what's happening, a human rights perspective, and learning to appreciate the differences across geographies and opportunities. So we really covered a lot. It was really another amazing discussion. Please join me in thanking our panel and our moderator. Once again, this was webcast live. We had close to 130 RSVPs, so we know we had many colleagues who have tuned in online. I've been tweeting about the event and getting responses. The event will be video archived. You can come back to it on our newsecuritybeat.org platform. The presentations will also be there. We will write a blog summary of the discussion for you. And now I'm not going to hold you back any further because we have lunch for you. So there's lunch just outside. Please stay, continue to engage, network, ask further questions, and engage the panelists further. Thank you, and keep coming. Oh my gosh. So rich. Oh, as usual, this superstar.
Oh, talk about superstar. I cannot believe that you have all of that. That summary was amazing. Yes, how do you do that? I don't know who you did that. Thanks, Amanda.